Good morning, everyone, and welcome to day 2 of our annual cost trends hearings. I'm David Seltz, the Executive Director of the Health Policy Commission, and it is my great honor to welcome you all here today for this second day of our hearing, second and final day of our hearing. And we have a lot of great topics to cover today and a lot of honored guests to provide remarks for us. Before we get to that, though, did want to just highlight a few logistical things for the audience and for those of you who are watching online. All of the slides and presentations that have been presented here at the hearings are online at our website and available for the public. So if you saw some slides yesterday or today that you're interested in, please visit our website, and all of those materials are online for you. Secondly, I want to thank Suffolk Law and for hosting us again this year, and specifically Renee Landers, who is the director of the Health Law program here at Suffolk Law University. This has really been our second home at the HPC, and this is our 4th year having the hearings here at Suffolk Law. It's a great venue, so accessible, and we're so pleased to be able to have this incredible public event at this venue every year. So I want to thank Suffolk Law University for everything that they do, and for all of the people here who work at Suffolk Law University on all of the AV and the tech and the setup. You guys just did an incredible job. Want to recognize also, again, yesterday we were joined by a tremendous number of staff from key legislators, both in the House and the Senate. We were also joined by Representative Christine Barber, who came and met with us for a little while. And I also want to recognize Chairman Jeff Sanchez, who is here today. Mr. Chairman, you are our MVP legislator of the cost trends hearings over the last couple of years. We missed you front and center yesterday, but glad to see you here today. Thank you so much for being here. I'm going to now turn it over to our chairman to kick off today's events. Chairman Altman.
Thank you, David. Chairman Sanchez, I did miss you too. I kept looking for you yesterday. I miss you all the time. Now that you're so powerful, I figured, we're just a bunch of kids running around. But I'm glad you're here. Well, as we talked about yesterday, and as David has mentioned, these hearings are very important to the commission, to the state. They are mandated by law that we should have them, and this is our 5th year, and we take them very seriously. They sort of form the basis for how we look at the health system. I thought yesterday was really very good. We focused on a number of areas that we're going to continue to come back to, and that is, how do we really keep the growth in our health care costs in line with what we can afford, but to do it in a way that improves the quality and access to care. And I thought our discussion about the right balance between community level activity and the activities that need to be done at our big teaching hospitals was very important. And we were very pleased to hear about the success of a number of our chart programs. So yesterday was a big success, and I am really looking forward to today. And we really are going to start off with a bang and have the Attorney General join us. And I'm going to turn to my colleague and fellow Commissioner Joel Cohen to introduce the Attorney General, but thank you for coming.
Thank you, Stuart. Welcome back, everyone. It's a real honor to introduce our next speaker. Not only is she the state's chief law enforcement officer, but she is also the chief executive officer and lead attorney of what has been properly referred to as the People's Law Firm. She has been out front on such important issues as immigration, consumer protection, opioid abuse, and of course, health care, where her office, working closely with the Health Policy Commission, has delved into such important areas as pharmaceutical costs and provider price variation. Please join me in welcoming Attorney General Maura Healey.
Well, good morning, and thank you, Marty, for that introduction and for all that you do, in particular, to improve behavioral health here across our state. I want to thank you, Dr. Altman, for your work and the work of everyone on this commission. It's indeed a privilege to be able to appear before you once again. My thanks to David Seltz and Ray Campbell and the entire staff at HPC and CHIA for all that you do throughout the year, not just in preparation for these important hearings. I want to commend and thank Secretary Sutters for her work and the work of her team on so many fronts. And particular thanks, of course, to Marty and to Don Berwick and to Dr. Cutler for your continued service on behalf of the Attorney General's office in regard to this effort. And I'd be remiss if I didn't acknowledge my own team, including Eric Gold, Mary Freely, Mary Beckman, Karen Sung, and Sandra Walitsky. Now, before I say anything this morning, if you'll indulge me, I just want to offer my deepest sympathies to the victims, to the families of the heinous attack in Las Vegas. Once again, yesterday morning, we woke up to horrifying news. I think about Rhonda LaRoque and her family. She's a resident of Tewksbury, as you know. She was killed, leaves behind a husband and a 7-year-old daughter. I spoke yesterday with the Nevada Attorney General and offered my support and my office's support. Unfortunately, we have some experience from the Marathon bombing and other events, and I think particularly with regard to the deep need they have for victim witness services, we want to do everything we can, and we will as a state. I want to acknowledge the bravery and the courage of the first responders and law enforcement and the folks who showed up yesterday and will show up again today to give blood. But I'm hoping and praying that at long last, this time our leaders will find the courage to do what is right, to face this as the public health crisis that it is, and to acknowledge that as with all public health crises, there are certain things that are preventable. I hope our Congress will take meaningful steps to prevent this kind of tragedy from ever happening. And again, in my short tenure as Attorney General, I've had many instances to reflect on and mourn these recurrent mass shootings that we've seen over just the last 2-3 years alone. So in the spirit of resolve and resilience, and hopefully in a moment where people can find courage to do what is right, I just want to ask kindly for a moment of silence. Thank you. Now, today we are here to talk about this incredibly important topic of healthcare. Speaking of congressional action, I want to briefly address the healthcare debate that we've been watching in Washington over the last several months. I think the headline today is that the ACA remains the law of the land. Whatever improvements are needed, I think we can all agree that that is good news. But here's the bad news. Once again, millions of Americans nearly lost their health care last week. And this, unfortunately, may come up once again. The latest bill took direct aim at places like Massachusetts and other states that have led the way on expanding access to care and investing in vulnerable populations through Medicaid. It's an assault on our states. It's an assault on our basic values. The bipartisan promise that we've worked so hard here in Massachusetts to fulfill, understanding that here in Massachusetts we believe that healthcare and access to healthcare is a right, not a privilege to be shared by only a few. It was an attack on every parent of a child with a pre-existing condition, on every family that has staved off bankruptcy and financial crisis because of insurance coverage. And in the midst of this roiling opioid epidemic, it was a gut punch to every family out there with a loved one afflicted by this disease. So as we gather today, I am proud to be from Massachusetts. I am proud that our teams can work together. We have the opportunity to work for you and with you to be from a state where we recognize and have led the way on some of these strong values. And I think it's important to remember that we have a role here, not here alone, but also nationally to lead, and that we can be an example of what it takes to work together. Democrats and Republicans, patients and providers, business and government, working together to ensure that everyone is able to get the care that they need when they need it. I think about that legacy, and I think sometimes it's good, especially in times that are challenging and difficult, to be reminded of some of the foundational principles and where we've come from. We're proud to have the best providers and health plans in the world, right here in Massachusetts. We're proud to have the highest rates of coverage in the country. And thanks to all of your hard work, we're proud to meet this year's cost growth benchmark. So I want to talk to you today about continuing on that progress, on building on that momentum. And unlike the cruel and regressive approaches we've seen out of Washington, that were once again attempted last week, I want to talk about leading the way by keeping vulnerable populations front and center in our conversations. There are three themes I'd like to touch on with you this morning. The first is that to build on our progress, we need the stability to price insurance effectively and the authority to protect our insurance markets. The governor spoke to this yesterday. It's an incredibly important topic right now. I know, having come recently from national meetings with other states, this is of top concern, and we all have a common goal and a common interest in seeing that this gets done. That's why my office intervened in the House v. Price litigation. Instead of threatening cost-sharing reductions, Congress should be working across the aisle to bring stability to our markets. And that's why we'll oppose any attempt by executive order or any other method to allow the sale of cut-rate health insurance plans that don't meet Massachusetts standards and that will hurt our residents and our families. Now, some in Washington like to call this selling insurance across state lines. We call it selling us a bill of goods. We know what this is about. My office has already brought enforcement actions against some of these players. It's just another way of folks attempting to undermine coverage for vital services like behavioral health and women's health care, and we won't let that happen. And speaking of undermining coverage, that's why we'll also continue to demand and join with others in demanding that Congress reauthorize the CHIP program and vital funding for our community health centers. Again, points that were touched on yesterday, they're incredibly important, and we must do everything we can here in Massachusetts, not allowing anybody in Congress to not be held accountable for not doing their job, for instead deciding to jeopardize coverage and care for people. The second point I wanted to touch on is social determinants of health. We previewed some of this in the last couple of years of commentary from our office. I want you to know we're continuing to focus on social determinants of health. You, the experts, know that the unfinished business in health reform is moving from a healthcare system to a well-care system. And that means recognizing the upstream determinants of health. 70 cents of every healthcare dollar is still spent on managing chronic conditions, even though the biggest determinants of health take place mostly in the community. Access to healthy food, exercise, stable housing, and prevention education. Investing in these social determinants can improve health and lower costs at the same time. You certainly see this borne out in the opioid crisis. It's what I continue to hear about everywhere I go from every local official I speak with. We know that this is a crisis that has touched every community in our state, and increasingly every family that I encounter, either directly or indirectly, has been affected by this. Now, all of us are focused on deploying an all-hands-on-deck approach to respond to this. Together, we're going after traffickers who are pumping heroin and now fentanyl onto our streets. We're working to make Narcan more available to first responders in every community. And we're working to break down barriers to treatment to ensure that families are able to get the help that they desperately need. But my view increasingly is that substance use treatment will get us so far. We really need to also make sure we take steps on the front end. And I think about today's second, third, fourth, fifth graders going to school. We've got to stop addiction before it starts. 90% of adults who are struggling with addiction started before the age of 18, 50% started before the age of 15. You know the stories. We all know the stories. It's clear that investment, as with anything else in life, a little investment up front goes a long way, and it certainly will make a difference here. That's why we're working with the medical community and many of you in this room to change the culture around prescribing. That's why we're investing hundreds of thousands of dollars from major settlements over opioid dispensing practices to fund prevention in schools. And earlier this year, we announced a partnership with the GE Foundation, the Heron Project, and the Epicenter Experience to launch Project HERE, which is an unprecedented $2 million commitment to youth opioid prevention. With their help, we're working to make substance use prevention education and toolkits available in every public middle school in Massachusetts. But I again highlight that I think this crisis has laid bare some of the failings that we have as a country when it comes to confronting and dealing with real issues of mental health, behavioral health, and substance use that for far too long have gone ignored or not properly addressed. And we see the product of that. We certainly see the product of that in our criminal justice system or in any district court you want to walk into within the vicinity of this building. And we certainly are seeing it in what we're seeing in emergency rooms and when it comes to healthcare costs. Employers are seeing it, businesses are seeing it, and most importantly, families are paying the ultimate price. So we can't do enough when it comes to this area, and I remain committed to working with all of you on that front in the year ahead. Now, the final theme I wanted to turn to is about being smart about our upstream investments. My staff presented data yesterday to anchor our conversation about differences in health burden across Massachusetts and the implications for needed investments in community health. As you saw in the charts yesterday, there are significant differences in the health burden being shouldered by different communities across our state. And too often, communities with higher health burden have fewer resources to invest in the determinants of health. As you continue with your hearings today, I hope you'll share good ideas about how to help our providers and communities sustainably invest in those communities that need our investment. For our office, one piece of work or one contribution is our work to update our community benefits guidelines. Earlier this year, I was proud to convene the Community Benefits Task Force that studied how to bring more transparency and effective coordination for those dollars. And I want to acknowledge and thank the members of that task force who are in attendance today. In particular, I want to thank Don Berwick for his involvement. This is an opportunity. It should be viewed as an opportunity to take stock of disparities and duplicative efforts and work with partners across this continuum, including the social services continuum, to better serve and support communities in need. There are so many people and institutions and plans and providers, organizations of goodwill, but I think it's about making sure that we've harnessed that most effectively, most strategically in the service of wellness and health. So my hope is that we prioritize an approach where hospitals and HMOs are continually learning from one another and sharing best practices. Now, particularly with what we're facing, is the time to do it. Now, when we have the strong foundation laid by the Department of Public Health's community health initiatives and the momentum from HPC's investment and certification programs, now's the time to do it. Now, when Mass Health is moving forward on the accountable care organization transformation and investing in social determinants, now's the time to do it. This is an important step for behavioral health integration, for partnerships with community organizations, and for recognition of the importance of those upstream investments. All of us, everybody in this state has a stake in this. Everybody has a stake in innovations that will contain costs and improve health. In the year ahead, I know that we'll all be talking and working closely together and following these efforts. But my point, as I began, is this. We have an amazing collection of talent in the room, and I certainly want to acknowledge and appreciate the work of Chairman Sanchez and his committee. When you think about, though, the collection of talent, expertise, innovation in Massachusetts, now's our time. Now's our time. I think that people here desperately need us, and people across this country need us. And we have a chance to lead the way and to get it done. And because we have some of the brightest minds and most committed people when it comes to the care, fundamentally the care and well-being of families and communities, I know we can do this. We can work towards a better well-care system in our state, in our businesses, the kind of system that our residents deserve. Once again, thank you for inviting me and my team to be with you here at these hearings. We look forward to continuing the discussion and certainly taking on and engaging in any efforts to improve access to health care. Thank you. Thank you.
Thank you, Madam. It's always a pleasure, and I want to tell you how much of a pleasure it's been working with your staff. They've been just wonderful.
Oh, I know.
Thank you.
Thank you.
Mr. Speaker, I really am so pleased to get the opportunity to introduce the Speaker of our House, Robert DeLeo. Mr. Speaker, I occasionally get the opportunity to go around the United States and talk about health care, and I can't tell you the number of times people in other states and in Washington have said, how did you do it in Massachusetts? How did you make it work? And I said yesterday, and I forgive for those of you who were here yesterday, last week I was in the little state of Delaware, which is crawling up to us as being the most expensive state in the United States when it comes to health care. And the introducer was a chair of the Ways and Means Committee, actually, of the state legislature, and he came over to me and he said, we're trying to do things here. He said, but how did you do it? And what I said to him and what I said yesterday, it was leadership. And it was your leadership and the governor and the president of the Senate brought bipartisanship. So I really want to thank you for all the citizens here in Massachusetts, but more importantly, that Massachusetts increasingly is the beacon of how we can make our healthcare system work better, be higher quality, and most importantly, be affordable to everyone. So it's really a pleasure for me to introduce you today and to have you speak before us. You set up Section 224. You've asked us to, this is the 5th year we've been running these cost hearings, and it makes it special that you can take the time to join us. So thank you very much.
Thank you.
Welcome.
Thank you very much, Stuart, for the extremely kind introduction. I just as soon end this whole meeting right there if I could, but I guess I can't. What's interesting about you had just stated was I can tell you that Massachusetts does lead the way, not only in healthcare, but in so many other different, on so many other different issues. You know, I can tell you when I attend the speakers conference, which I did, I don't know, some 2 or 3 weeks ago now, I find that many times not because of my particular expertise in anything, but because of being the speaker from Massachusetts, almost become the center of attention in terms of what's going on in so many different topics in this country. Healthcare has been one of the major ones. I have to say, in past topics, gun legislation has also been, I think if that conference was held today, there'll be a lot more discussion about what we did right here in Massachusetts and why Massachusetts, especially working, I don't know if the Attorney General is still here, has become the leader with regard to controlling gun violence. So what you say in terms of where Massachusetts is looked at in the spectrum of the country with respect, I think has been wonderful. And I want to thank you, and it's good to see David here as well, despite the fact that he never worked for the better branch of government. It's still good to see him. He picked up bits and pieces of knowledge as he went along, which led him to this his position here today. But I sincerely want to thank you for the incredible work and for hosting this hearing each and every year. Chapter 224, including the cost trends hearing, is having a very real and positive effect on the healthcare market. It is because of your vigilance and thoughtfulness that we are the nation's leader in healthcare. That said, I believe that this year marks a critical juncture for our healthcare market. We here in Massachusetts have set the national example of what can be achieved through healthcare reform. We should be proud that more than 98% of our residents are insured. Reports from CHEER show that we've been successful in slowing the growth of spending, despite a challenging fiscal and political landscape. We have the best healthcare facilities in the world, and we continue to be the hub for medical innovation. Just yesterday, MIT and Brandeis professors were awarded the Nobel Prizes. And last month, Reuters ranked 2 Massachusetts schools in the top 10 of the world's most innovative universities. At the same time, it is clear that our current trajectory is unsustainable. And after several years of watching our system develop, as the provisions of Chapter 224 were implemented, we have a fuller picture of how Massachusetts Health has dominated our state budget. At times, its escalating costs have prevented significant investments in our social services. One, I think that our Chairman of Ways and Means has learned very, very quickly in his relatively short time as serving as chair. At the same time, patients are spending an increasing amount of their income growth on healthcare spending. The House is committed to finding meaningful solutions. Chair Sanchez, Colcott, and I have been meeting with a broad range of stakeholders as we continue to explore a variety of policy topics to help us address healthcare cost containment. We're focused on consumer information and engagement. We want to zero in on how we can empower patients to make choices that are most beneficial for themselves and their families, while also helping the overall system. CHEER's new website may be the key to getting people the information that they need, but it's also about changing attitudes. We are going to have to work together and within our communities to make this possible. We may also have the opportunity to reevaluate how our agencies are supporting the healthcare system and the consumers. There's a space for a discussion about agency collaboration and finding ways for agencies to provide patients with more information. We're excited about the potential of telemedicine, and we're thinking about how innovation can help us balance cost with quality. We're also taking a look at pharmaceutical spending and transparency. We need to strike the right balance between bringing down spending while maintaining our robust innovation ecosystem. We have identified a few avenues, I should say, that in partnership with the pharmaceutical industry and payers could yield meaningful data and increase accountability. Importantly, we will not let the work we've already done go to waste. The recommendations of the Provider Price Variation Commission, which received broad support from diverse stakeholders, are playing a critical role in our discussion. In particular, proposals to address out-of-network and surprise billing, support small businesses, and to create a framework for price variation factors are worthy of our examination. As many of you know, the House has long focused on behavioral health. We know that behavioral health continues to be a part of the underlying narrative about costs. More than 60% of hospitalized Medicaid patients have a behavioral health condition. Yesterday, Dr. Maddox said that high-cost patients are 3 times as likely to have a mental health illness. In 2015, our MCO working group, headed up by Chairman Sanchez, found that the continuing impact of addiction and mental health complicates patient needs and poses administrative challenges to both payers and to providers. This was reiterated, I believe, in the panel discussions yesterday. The intersection of behavioral health and addiction has been a personal priority, and I have been deeply impacted by visits that I have taken and seen for myself to emergency departments, recovery support centers, and support groups. I have learned how frequently mental health problems coincide with addiction. About 9 million adults have co-occurring disorders, yet only 7% receive treatment for both. We have taken a significant step forward on how we treat behavioral health, particularly addiction, but we face challenges. If you allow me, I'd like to enumerate a few here. The number of behavioral health-related emergency department visits, including those related to opioid use, have increased. Those with behavioral health conditions are kept in the ED longer than non-behavioral health patients. And behavioral health conditions have health care costs that are significantly higher, sometimes 2.5 times higher than other patients. We owe it to those struggling with mental illness and addiction. We should be thinking more holistically about their care. We need to find ways to coordinate treatment and ensure that providers are held to the highest standards. Lastly, we continue to work on the administration's proposals. As Commissioner Commissioner Secretary Sutters will tell you what she calls me every day, every week and whatnot, just to check on progress. Thank you, Madam Secretary.
Thank you, Mr. Speaker.
The House feels that Governor Baker's proposal contains some very valuable ideas. At the same time, some of those require more work, and others may not be tenable in this particular climate. It is my foremost concern that the Commonwealth does not save money on the backs of the most vulnerable. Our ongoing conversations are helping us to determine who would be affected by each of these ideas that I have just mentioned, how we would implement them, and what the long-term impact on the Commonwealth's healthcare system and economy would be. We will continue to work together with to make sure, I should say, that Massachusetts remains a leader in healthcare and that every resident receives the care that he or she deserves. We also continue to closely monitor how the federal government may change the Affordable Care Act and other elements of healthcare insurance system. I can tell you personally, watching the news each and every morning to see what's going on in Washington has become a general routine for me. And never have I seen myself working and praying so hard to see that legislation doesn't pass as I've had these past 2 weeks. While it's been very challenging, I'd have to say, to plan ahead with so many unknowns, you have my word that regardless of what happens in Washington, we remain committed to our core values. Thank you very much, and thank you so much for this opportunity to say a few words this morning.
Thank you so much, Mr. Speaker, and we look forward to working with you and your staff and Chairman Sanchez back there and his staff. So thank you so much for your leadership.
Thank you.
It's been wonderful.
Thank you for your kind words.
All right, we're going to now move to the panel discussion, and I'm going to, David, you're going to come up, and so we're going to, will the panelists please come up? I do. Thank you.
Thank you to the Attorney General and to the Speaker of the House for those really excellent remarks, and I think we'll tee up a number of the themes that we're going to be talking about here today. Before we move to our next panel, which is entitled Promoting High-Value Care Through Payment Reform and Purchaser Innovations, I want to share with our panelists and with the board and with the public a few summary stats sourced from our pre-file testimony, specific to the topics of this panel. So here we have a summary of some of the findings we had heard from both health plans and providers on topics of our advancing alternative payment methodologies, new payment policies, and the increasing transparency of our healthcare system. Starting on the left-hand side with the two blue boxes, we asked health plans what are their top strategies for expanding alternative payment methodologies that promote value instead of volume. And they told us that their number one strategy is expanding into public programs and expanding through the new MassHealth ACO program, as well as through Medicare Advantage. When we asked what types of areas in terms of providers that they were interested in expanding APMs to, they noted an interest in moving beyond primary care APMs to also include other provider types, such as specialists. We asked providers, what do they see as some of the key barriers to adopting more value-based payment? And they noted a lack of alignment among many different elements of alternative payment methodologies, including quality measurement, that complicated their efforts to perform and succeed under these payment methodologies, and a lack of resources to invest in the necessary infrastructure. They also noted to us that even these global payments are still generally conducted on a fee-for-service chassis, which is to say that there is a fee-for-service reconciliation at the end of the day that may blunt some of the incentives to reduce volume. We asked health plans what are their payment policy innovations that they are exploring. And interestingly, 100% of the commercial health plans that we asked said that they are putting in place payment policies around readmissions. Those vary significantly by health plan. We heard that 82% of the commercial health plans have introduced policies related to telemedicine, something that the speaker just mentioned. On the other hand, we heard that less than half of the commercial health plans have specific payment policies around behavioral health integration into primary care, and a very few have policies related to services to remove and protect patients from violence. We asked about the complexity of the quality measurement and heard from providers that there are over 100 different types of quality measures being used for alternative payment methodologies. Finally, and again, speaking to something that the speaker just mentioned in terms of consumer engagement and transparency, we have been asking the health plans over the last couple of years to track the utilization of their members of their health transparency websites. How many visits are they getting on these websites, which were launched as part of a requirement under Chapter 224. And the top health plans in Massachusetts, the top 8 commercial health plans, reported around 180,000 inquiries in 2016, a significant increase from the previous calendar year of up to 30%. So with those stats in mind, I'm going to turn it back over to the chairman to tee off our panel.
Thank you, David. So first, I'm going to ask each of the panelists to introduce themselves very briefly, your name and the organization that you represent, and then we'll engage in discussion, and I'm sure during that discussion, you'll get the opportunity to say a few things that you really want to say. So why don't we start with you, Deborah? Thank you all for coming, and we look forward to this discussion.
Thank you. And I'm Deborah DeVoe. I'm the Chief Operating Officer of Blue Cross Blue Shield of Massachusetts.
Deb set the tone to be brief. I wanted to first say thank you for inviting us here to what's become a fall tradition. My name's Roberta Herman. I'm an internist and epidemiologist by training, and previously have practiced as a clinician in Cambridge, then moved over to the health plan side, more recently as a consultant, and now as the executive director of the Group Insurance Commission.
Good morning, and thank you all for holding these hearings. I'm Steve Strongwater. I am the president and CEO of Atrius Health, which is a fairly large primary care integrated specialty group and a VNA care and hospice program.
Good morning. My name is Trish Hannon. I'm both a nurse and as well CEO of New England Baptist Hospital, a proud partner with my colleagues here on the dais. So thank you for inviting us.
So let me just get the questions going, and then I'll turn it over to my colleagues. First, let me turn to the Blue Cross and the GIC, and give us a sense. I know the Blue Cross in particular recently made substantial strides in moving alternative payments to its PPO platform, building on what you had learned in your HMO. Give us, both of you, a sense of the good and the difficult aspects of moving to new payment, and how do you see it moving forward in the future?
So let me start with a brief background that Blue Cross had introduced alternative payment methodologies for our HMO products in 2008. And we moved to offer PPO alternative payment methodologies for our PPO products in 2016. So the first providers came into managing PPO members in an alternative payment in January of 2016. We do have approximately 35% of the primary care physicians and about 50% of the specialists in Massachusetts that are participating in the PPO alternative payment model now. I'd say the three areas that we would highlight in terms of both what will enable us to make progress and other challenges. I guess all three offer each opportunities and challenges. are first the interest of provider organizations in accepting PPO alternative payment methodologies. And we do not require provider organizations to accept this model in order to be in our PPO network. We don't feel that it's appropriate to require providers to accept this. So this needs to be a voluntary effort that's consistent with that provider's mission and also their belief in what is reasonable for their organization. And there are some significant concerns by some providers about accepting accountability for a PPO population who does have different structural components in their coverage. So I'd say the first factor is the ability to have providers participate. The good news is that we had very significant participation in our first year, and we are seeing that participation level increasing. I'd say the challenge is that this may not be for everyone. And so, so that's the first factor. The second factor is that it's important to understand that our contracts, Blue Cross of Massachusetts contracts with Massachusetts-based providers can only be deployed for those of our members who live in Massachusetts. So I think as many people understand, we offer coverage to employers who have their headquarters in Massachusetts, but they may have employees throughout this country. In fact, we, during all of the recent crises, we realized that we have several 100,000 members that were in Texas, Florida, Puerto Rico, et cetera. So our plan covers the employees of employers who are based in Massachusetts and whose employees may live nationally. So about half of the members that have PPO coverage live in the state, and about 35% of the primary care physicians are participating. So as you can see, the second challenge is how many members will have the opportunity to have access to the PPO contracts in this state. First, their employer has to offer the product, and then secondly, their provider has to participate, and they need to be living here. So again, we're very pleased with the progress. Other Blue Cross plans nationally are also adopting alternative payment methodologies. So as we sit here today, we have 300,000 of our members in Massachusetts that are being cared for through our contracts. And then we have about another 126,000 members who have a Blue Cross coverage in other states who are being cared for through other Blue Plan methodologies. So we do see APM for PPO growing, and we do feel that both in our state and nationally, there's progress. And then the third element that I would mention in terms of both progress and a challenge is the ability to attribute a member to a physician practice for PPO. So as you know, in our HMO products, the members select a primary care physician. In our PPO products, our state has worked through a methodology for attributing members, and we attribute members to a practice if they have had either a visit or 3 prescriptions with that practice in the last 2 years. And we can attribute over 70% of the members, meaning that we would identify who we think their practices that they would consider to be their physician of choice. The member can certainly opt out of that. They can either correct us and inform us that they have a different physician of choice, or they can opt out. Very, very few members have opted out, and few members have needed to correct us, but that is available. And we can attribute about 70% of the members, But what I would say is that that is the other factor that comes into consideration when we think about the program.
Thank you.
Stop there.
Dr. Herman?
Hi, well, a little over a year into the job, what I would say is that the Group Insurance Commission and its members are starting from a really interesting place, because where, and this, I don't take any personal credit for this work, but where the Group Insurance Commission has really been a leader is around the implementation of limited and tiered network products. I can say more about these later if you'd like me to, in terms of what's been successful and not there. But the limited network products really focused particularly on choices around hospital. And so the goal with those products was to simply take the highest cost hospitals out of the mix. And no surprise, the trends there are favorable. And actually, there are some very interesting data from a study by Gruber et al. That demonstrate that, if anything, there was an increase in primary care utilization and a decrease of high-cost services. So about 30% of our members are already in limited network products. For the remaining 70% or so, we have so-called broad network products with a tiered implementation that focused on specialists. And we're now at a point, at 14 years into it, where the high-volume specialists are tiered, tier 1, 2, 3, with copays of $30, $60, and $90. And the main goal there is around steerage to the most cost-effective providers. Number 3 is the IRBO initiative, which was implemented approximately 2013, and is really the Group Insurance Commission's version of an ACO model-based product. And what's really interesting there, sort of a couple things. One is that the adoption has been quite remarkable. We're actually at 52 to 55% of members attributed to practices that are in these kinds of arrangements. It hasn't been possible so far to demonstrate any savings. So what I would say is that a couple things. One is many of the issues that Deb also already mentioned, I will not go through again in detail. There are the methodologic challenges. But the other thing is that it takes a long time. So even under the best of circumstances, we would expect it to take many years to move from simply adopting the model, which, as you said, is usually on top of a fee-for-service chassis, to getting to the point where there is true transformation of how care is practiced. Those are huge changes that require many things that we don't have direct sight lines to or control over, including leadership, data infrastructure, all kinds of programmatic capability. So it takes a long time, and the incentives need to be there for the practice to invest. Our major challenge has been, how do we integrate all these efforts? And how do we participate in a way that's constructive for the community at large? And so there was a little bit of a tension, frankly, between the individual specialty tiering and the group model that the ACO is structured under. So we're now undergoing a kind of migration over to group-based evaluation. That's one. Number 2, we're really working to align our efforts. And so in the next healthcare procurement, we are specifying that it's going to be the Health Policy Commission targets that form, and the ultimate market performance that form the expectations. Why not link these things? We've also been having a very active conversation with Ray about how we can basically align the way that we measure performance and cost targets over time, so that we're not having multiple conversations or inadvertently getting in each other's way in terms of our effectiveness. So I see that as a really important terrain.
I just had a quick follow-up question, Roberta, and that was very helpful. Yesterday, when we had the panel with academic medical centers and the conversation about how do we shift appropriate care from academic medical centers or more expensive settings to community hospitals, this issue of it takes time came up several times, and we could certainly appreciate that. You've said the same thing in terms of how do we speed the adoption of some of these alternative payment models. What can we do besides, particularly at the commission, besides setting different targets? What can be done in the provider realm, in the payer realm, the commission level, to speed that process up? So next year, we're not sitting here talking about, well, in another 5 years, we might be there.
So I should really, really make clear that my intention was not to suggest that we wait 5 years. Any of you who actually know me know, if anything, I'm not a very patient person. So I would really like to see more movement. Certainly continuing to beat the drum around transparency and comparative performance evaluation. That would be one. Secondly, not allowing the perfect to be the enemy of the good. We could debate for centuries what the optimal measurement, quality measurement regimen is. I think we need to find a way to turn the conversation the other way around. It feels way too often like very well-meaning institutions go about creating measurement schemata that then just get blown up when they're put in front of the provider community. I would like to invite the provider community to be the ones on the hook for really helping us to develop the appropriate measures. It feels kind of backwards to me often right now. Last but not least, the kinds of initiatives we will be moving forward with and have been moving forward with. One are things like our Smart Shopper initiative that basically creates incentives for members to shop around and share in any of the savings that may result from the choices that they make about care. Another is Centers of Excellence programs. I believe that until or unless there's a potential implication around shifts in volume, it's really hard for the provider community to feel the need to respond to some of what's going on. So those are some places where I think frankly, that if the Health Policy Commission could get behind and provide appropriate data, you could be helpful.
Thank you. So I'd like to build a little bit on what you just said, Dr. Herman, and what has been presented by David Seltz also. David showed us that there were 106 quality metrics that across the board that people had to meet. I like that you said to invite the provider community to develop appropriate quality metrics. Especially, I would like to see more outcome metrics. So my one question is, and last year at our Class 10 hearings last year, we heard both from providers and from insurers frustration about lack of alignment of metrics across different payers, and so that providers are in this quandary of how do I teach to the test, basically, or do I just do the best I can and choose the ones that are important to me? So I guess I'd like to hear from, Blue Cross Blue Shield, how, as a leader, how do you work with other insurers to make sure that there's a limited set but meaningful set of quality metrics? From you, Dr. Herman, how can you, in your role at the GIC, sort of guide that discussion since you work with multiple insurers? And actually from you, Dr. Strongwater, also because I've heard you speak very eloquently at a New England Journal Catalyst program about some of the administrative burdens on practices and how this impacts. And I do think that one of the frustrations of that is leading to physician burnout is having to deal with all these metrics and requirements, and how do we get the physicians to become the leaders and say, these are the things that matter, this is what we're going to work toward to try to improve the health of our community.
I'll say a couple things. So first of all, when there is discussion about, for example, there being just a panoply of diabetes measures, there are sort of two different issues. One is that often the very same goal is done in just a slightly different way among several plans. And the fact of the matter is that if you're doing a good job managing diabetes, you really should do well on all of them. So there are two different issues. One is around, what should you be doing programmatically? And I think programmatically, you should be doing pretty much the same things. The other is just the sort of nuisance of the slightly different metrics and what that means for your analytics folks and the docs that are trying to understand it. It creates a lot of confusion. So I know that there are already, several efforts underway, which we will more than happily participate in, including there's an EOHHS Quality Measure Alignment Task Force. There's the SQUAC. Ray, I love that name. The Statewide Quality Advisory Committee. at CHIA. The Health Policy Commission has also kind of stepped into this train. I do think that it's really, really good to have conveners. And I also believe, as I said before, that what we want is the provider community as active participants in the process.
Tim?
Just wanted to follow up on Wendy's question about what we can do. Clearly, as was stated yesterday morning by the Senate President and today by the Speaker of the House, there's clearly going to be a debate ensuing in the state level around all these issues. And I'm wondering what your thoughts are. What would be one key item you think is important for the legislature to address in order to increase people in the APMs, but also how to promote high-value providers? What would be one or two suggestions you would have with folks in this room who are drafting legislation? What would your thoughts be if they need, what needs to be included in that piece of legislation to continue the progress that's being made?
See our providers join us in this answer. How can we push?
Well, we're strong advocates for alternative payment models, and I think the targets that have been identified as it relates to areas like substance abuse, behavioral health, and hospital readmissions are clearly there. I would argue we have potential opportunities for improvement. As an example, we know that paramedics can help reduce readmission rates, and we've been a little bit stalled in deploying those opportunities. I think we should give some thought to recognizing different types of behavioral health providers as billing providers and provide not only access but parity for payment, which would allow a larger number of workers in the workforce in that context. I think there are very discrete opportunities to recognize other providers like clinical pharmacists who I believe in the chronic disease therapy management space could help with pain management and substance abuse management, areas we really haven't pushed on. They would have to be, again, recognized as providers. And I think we could expand the scope of others that would help reduce the work burden. You know, there are things that physicians in the context of burnout are asked to do, signing certain forms. I'll use an example of admitting somebody to a nursing home. We will not accept a nurse practitioner as the final admitting person to do the history and physical. It requires a physician to come by and do that. It seems to me that people should be recognized at the top of their license and that those kinds of interventions could help to reduce the cost of care. So the targets, I think, we understand. I think there are some strategies that have worked in other states, and finding ways to accelerate the deployment of those strategies would help us here in Massachusetts.
I would certainly echo what Steve had to say about working at the top of the licenses and providing opportunities for paraprofessional roles to be enhanced, particularly across the continuum of care. Speaking as a provider, as a specialty provider today, I would say that to answer your specific question about as you look at the legislative activity, one of the key considerations for us, speaking specifically for the New England Baptist Hospital, is that consumers today are not being given the opportunity in a very transparent way to understand not only what their health plan can provide for them, seeking value providers, which you've heard earlier from Roberta Herman and from Deb, but also in terms of the incentives or disincentives that are put into place through the networks and their PCPs. So if PCPs are preventing patients, not because of their desire to have the best capability on behalf of their patients, but because of their incentive or disincentive programs, that's very important. It's important for consumers to be aware if there's physician ownership, if there's self-referral. It's very important for consumers to be aware that those choices can be made for high-value providers. It's one of the biggest challenges as a provider that we have. We've played Switzerland for 125 years. It's no longer an opportunity for us, given the nature of the very closing networks. We find that we're paid for price and not for value until we've had the opportunity to work with Blue Cross on our first pay-for-performance contract and until we had the opportunity to work with the GIC on a Center of Excellence approach, which I think we're very, very pleased with both of our organizations. It's been a very long time that we've been shouting from the rooftop about people are talking about pay for value, but we're still paid on a fee-for-service basis primarily.
Can I jump in? First of all, I'm so pleased you've joined us. This is the first time I think you've joined us. And 2 years ago, we singled out Baptist for the high quality and the good value that you provide. So, I want to thank you. I'm troubled, and I'm curious whether you think it's a good thing or not. I'm troubled by the fact that the federal government is backing away from its bundled payment system. And I just was curious on how, as a leading, if not the leading, orthopedic type facility in the country, how you view bundled payments as a positive, negative, neutral. How do you see it going forward as a way of improving value and quality?
We actually see it as very favorable. We've been ready to bundle for 5 years, and the market hasn't been ready to bundle. Until we were able to enter into a unique and I think very valuable relationship with the GIC as it relating to episodes of care, both prospective and retrospective bundles. We believe that the future of our organization is predicated on us ability to managing risk within an episode of care, whether it's for a period of a year or a period of 6 weeks in a perioperative period of time, to be able to manage to an outcome, goal-oriented outcomes. And we want to be paid on that basis. Our position has been that the market's not been ready to do that. We understand that it's a very complex set of issues that the market's grappling with, and certainly musculoskeletal care is not on the top 3 issues associated with total medical expenditure. But we think that there's an important value proposition associated with our position in the market. We're very proud providers of care throughout New England, and we are very much pushing the bundling aspects of care as much as we possibly can. If you were to ask Roberta how many times her phone rings from me on pushing that even further, I think that she would tell you that it's often.
Madam Secretary?
So thank you for segueing that to episodes of care. So we've heard a little bit from the governor, we heard from the Senate president, we've heard from the speaker and the attorney general, singing to my good friend to my left here on behavioral health. So why have we not, so I'm going to push all of you on behavioral health. Maybe not my specialty hospital here, but you can talk about co-occurring, just maybe there's like a co-occurring thing between skeletons and behavioral health. There probably is. But so why have we not explored episodes of care for behavioral health? The outcomes stink. The comorbidity stinks. High rate of emergency departments. Can't just blame Mass Health on this. It's all of us sharing this. We carve it out. We carve it in. We don't pay enough. I think I'm the only payer in the group who actually has increased payments for behavioral health, which is not enough. And we just keep squeezing it out. So treatment of addictions seems to me perfect for like episode of care. So I'm sort of interested in, I'll leave Trish out. I'll come back to a knee thing maybe, but so where are you on, I'm really tired of people telling me we're integrating behavioral and physical health care, because I see the talk, I hear the talk, but, so tell me something different when it comes to behavioral health that I can have some hope on.
Do you want me to jump in?
If you want.
I always tend to wade in where no one else will. A couple of things, Mary Lou. So you are tired of hearing about it, but we did recently increase rates for providers with our behavioral health partner. And secondly, for what it's worth, in the upcoming procurement, we decided to carve behavioral health back in. We'll see what happens. We haven't yet talked about bundles per se, but something else we are talking about that I think is at least moving in the right direction is a kind of preferred network of organizations that do a proper job of treating addiction, because it's really kind of a mess out there right now. And that feels to me like an area that is very, very ripe for creating a centers of excellence kind of program. Inevitably, once we agree or establish an appropriate network, where the conversation will have to go next is around bundles. So that's where our thoughts are today on that point.
Yeah, and I would say that we have not thought about the issue that you're raising, using episode reimbursement for behavioral health specifically. We are certainly open to considering that if the providers that we work with are seeing that as a important vehicle. What I can say is that when we first began offering alternative payment methodologies, there were provider systems that did not feel they could include behavioral health, either because they didn't feel they understood the issues or had the appropriate network. And as we sit here today, those models do, with each of our contracts, include behavioral health. So I feel like we've made progress in terms of aligning the payment methodology in the right direction, but we've really not closely examined the issue you're raising.
Okay, so just to be the skunk at the garden party, should the Commonwealth of Massachusetts require anyone who's licensed to practice to take all insurances in behavioral health? That'd be one I just put out to everybody. And the second is, what responsibilities do the plans have to really go through their networks of their providers and to help families and individuals who need mental health services and addiction services really understand who the panel is of their providers? Because I might be an LICSW, I was at one time, but you wouldn't know as an LICSW whether I specialized in adults, kids, geriatrics, CBT, whatever. If I was licensed psychologist, do I practice forensic? Do I practice blah, blah, blah? So what responsibility do we have as plans to also be clear that our behavioral health and addiction specialists are treaters, right? Like, I'm not going to go to a cardiologist for a primary care problem, just like you wouldn't want to send me to a social worker or a psychologist or a psychiatrist that doesn't specialize in what I need. And so when you look at, if you go on to various plans and the like, I don't really care if the provider is 10 miles from my home or not. What I want to know is that the person that I've been referred to is really someone who is going to be able, one, has an opening, two, can see me, and three, has the skills to help me manage my mental illness or my addictions problem. So I just sort of, those are the two that as we sort of think through some of this stuff, I just, again, just being the skunk at the garden party, just to push the issues a little bit. We're, just sort of, because we keep talking about integration, we keep talking about behavioral health is important, and, and yes, we are definitely doing some things on the margin, but I guess I don't feel like that needle has moved quite far enough yet.
Yeah, I respect your observation that the needle has not moved far enough, but completely agree with that. On your second point, what is the health plan's responsibility to support members in finding the right provider? I would say we completely view ourselves as having that responsibility. I would say that on all three factors that you're describing, getting the right expertise, having access, and having that scope of understanding the geographic fit and being able to make a fit there. So we definitely accept that as our responsibility. What I would say is that our experience is that while we need to have the information available to our members in an accessible form on our website, that there really isn't a substitute for our members being able to call in and talk to an expert at our end who can understand their problems and issues in more depth and to make that fit. And so we do employ experts in key fields, including substance abuse, who have knowledge of the providers in our community and can help when members need that consultation.
So as kind of a purchaser and an employer, one of the things that strikes me, I don't know how to entirely get at this, but people go different places, and not everybody really regards their health plan as the place they would first go for advice about these kinds of things. So I agree that if somebody shows up on the doorstep of Blue Cross or one of our health plans, they ought to be able to be counseled, as you described. One of the things we've decided to do next year is to expand the EAP program for members of the Commonwealth. And one of the many reasons for that is because one of the places this does show up for our members is in a workplace context, and you don't want people feeling like immediately they have to label as behavioral health in order to access services. I'm sure there are also community resources we should be investing, so my sense of it is you need multiple potential points of contact, and yes, each of them should be able to provide advice to members about where to optimally seek care.
Don?
Thank you all. It's my belief that around the country, value and value-based purchasing is sometimes used as a sort of code for just low-price purchasing, as Trish was saying. The evidence against that would be that you, as payers, sometimes reject putting in a favorable tier or in a limited network a provider who is low cost but just doesn't meet the quality grade. And I guess also that sometimes you would say, welcome to a favorable tier for a higher priced provider who's just superb. Do you do that? That is, in truth, have you rejected providers who are low cost because they just don't make the grade? And how often does that happen? And do you take value into consideration in the sense that you sometimes include providers who really are not at all the lower cost but are just terrific at what they do? Really?
Go ahead.
Yeah. Yes, really, on both counts. So at Blue Cross, we offer two types of networks that recognize providers for quality and cost. And one type is a tiered network where all providers that meet the quality standards are included. And the cost sharing varies depending on their cost. So basically, our representation to the member in tiered networks is that we do measure the providers on quality. They do need to meet those standards. But then the cost share varies based on what tier the provider is in for their overall cost. What I would say is that there are two types of algorithms that we use to look at cost. One is total medical expense. And in that algorithm, a provider who may have a higher cost per unit, so they may look like they are a higher cost provider, could produce a total medical expense that is favorable. And there, that provider would be included in a more favorable tier. A good example of that is a provider who may have a higher cost for each admission, but who avoids readmissions at a better rate than another provider. So we do try to recognize both of those circumstances. And then we also have a limited network where, in order to qualify for the limited network, the providers do need to meet quality standards, but then we are only including the lower cost providers in that network.
So I just want to, Marty.
Go ahead.
So if what you described is still a cost-driven decision, because you're using a threshold view of quality, which once you're over the bar, we don't look at you anymore. You've made the grade. But above that bar, and I'm just exploring, above that bar, you actually don't say, well, they're so much better, right, even though they're higher cost, we're going to include them in such a way that the patient isn't paying the difference. It's still a cost-driven system with a minimum quality standard that you're describing.
Yes, we do show the data around the quality performance, so that we can look at those differences. But we don't have a mechanism to rely on that would enable us to differentiate the quality in a way that would do what you're describing. That's true.
Trish?
Oh, sorry.
Just a note about the tiering. From our vantage point, we find ourselves in a situation where we negotiate against ourselves in order to stay in the lowest cost, highest quality tier because there's no steering mechanism. So if there's no steering mechanism in tiering, then the high value providers, those that are lower cost, high quality, find themselves tiered, but not necessarily the recipient of more patients to the system. And so that mechanism of sort of that passivity within the system doesn't necessarily contribute, in our view, to opportunities to lower cost and enhance quality wherever possible. So that's work that I think is still yet to be done. We certainly value our position in tiering. We think it's an important consideration, but it's not the only consideration.
Now, let me jump in here on this, because you've raised a very good point about the fact that the current system does not steer enough patients to the high value. And Deb educated me, and I'd like her to educate the whole group about, I pushed her on the Price Commission why you don't give individuals who join the lower tiered more of a benefit so that there is more tiering. And Deb, why don't you explain why you have not been able to lower the price for the lower tier?
Yeah. Well, we do. We do have a variety of tiered products that range in premium differential now between about 7% to about 20%. So we are making some progress on that front. What I would say is that one of the barriers to tiering even more effectively is that we do not require all providers to participate in the tiering, so they can opt out if they choose to. And if a provider opts out of the product and is not included in the tiering, they can require that we pay charges for emergency services. So as you know, a certain percentage of services that are received by patients, they don't have a choice about where they're received because they're in an emergency situation. And if we have to pay charges for those services, it decreases the value of the tiered network significantly.
Didn't you say close to 50%?
It can be close to 50%. So if we were able to achieve, for example, a 10% difference in the value of the tiered network, that could be completely offset by the costs that we need to pay for emergency services. That's why, as a member of the Provider Price Variation Commission, I was encouraged to see one of our recommendations be that providers in our state work with the plans to determine a fair level of reimbursement if they see an emergency patient on an out-of-network basis. And I feel that the providers on the panel were very open to that. They don't want the unintended consequence of a patient ending up in their emergency room and them treating them to have this impact on tiered or limited networks. Did that answer your?
Thank you. David?
Good morning. I can't help but follow up on the Secretary Sutter's question. Dr. Strongwater, Blue Cross Blue Shield just testified that they have made improvements in their reimbursement for behavioral health services. Do you think that their contract with you provides sufficient and adequate resources for behavioral health integration?
Well, we have full risk with Blue Cross on behavioral health, so I would have to say that it's up to us to manage that. I would like to say that generally the field of behavioral health is not as mature in measuring process and outcomes as other fields. And early detection would be really helpful. Bundled payment would be one mechanism, but we're at full risk, so it wouldn't be as relevant for us. But I do think the field of behavioral health is an area that really needs a lot more exploration, is no doubt. There are two things I just would like to add that are unrelated as it relates to sort of the policy issues that were posed, the question that Mr. Foley asked earlier, and that I neglected. One, which is happening around the country by another Blue Cross, Anthem, which are reduced payments, or rather site-neutral payments for advanced imaging. And the other are penalties, financial penalties for readmissions that, from a policy perspective, could be also examined. I apologize, I forgot to mention those earlier. Appreciate the opportunity to add them.
I just will follow up really quickly. Blue Cross Blue Shield plans in other states, Anthem, have adopted some of the policies that Dr. Strongwater just mentioned. Is Blue Cross Blue Shield of Massachusetts looking at those as well? And reflecting on the conversation from yesterday, what is your thinking in terms of adjusting those policies based on socioeconomic factors for members?
Yeah, so just to expand a bit on what Dr. Strongwater and what Commissioner Seltz are referring to, there are other Blue plans in the United States that have equalized payment for certain services across site of service. So the payment for a scan in the hospital would be the same as a payment for a scan in a freestanding facility, and have stopped payment for unnecessary ED, emergency department visits, or for readmissions. So what I would say is that we are, Blue Cross of Massachusetts is being asked this question by consumers. Why would Blue Cross pay a different amount if I have my scan done at a hospital-based facility or an independent facility? Members are seeing those costs more and more as they're participating in high deductible plans. They are seeing that cost and trying to understand it. And employers are asking us why we would not move further on emergency department and readmissions. So what I would say is that we have to stay open to examining that further. At this point, what we do for readmissions is that if a patient is readmitted to a hospital for the same or similar diagnosis within 7 days for our commercial members or 14 days for our Medicare members, we bridge the admission, meaning we treat it as one admission. And that is accepted and understood by the hospital and physician community alike. I would say for ED service, for emergency room services, it's a more difficult challenge because we have the standard that we want to use a reasonable person's judgment about going to the emergency room, and we do not want to create a situation where a reasonable person is afraid to get care because they are concerned about getting a very large bill. And in our state, I feel that many of the provider organizations, Atrius being a lead in this, have expanded their access to include other avenues for being seen besides the emergency room. And we are feeling that there's progress in terms of access to other services, both extended practice hours or urgent care, retail clinics, telemedicine. So I'm hopeful on that front that the private market and the provision of services by the systems in the state are making progress on that. And then what I would say about the issue of potentially neutralizing the payment on services in hospital and in freestanding facilities, we have to this point tried to address those cost differentials within our negotiations. I think we do have to stay open to considering other alternatives as we move forward. We do have to recognize that because we have alternative payment arrangements in place, we don't want to disrupt the provider's ability to manage care in their own system. So I would say that would be the other factor. In other words, where we have an alternative payment mechanism and the provider views a certain site of service as being important to manage, we have to include that in our consideration.
Marty, I didn't.
Sure. Part of the promise of alternative payment mechanisms is flexibility in my mind, and we've heard lots of discussion yesterday, and the Attorney General references it today about social determinants of health. And it sort of builds on some of David's question. I'm wondering sort of what you're looking at as in your payment models that would allow support for social determinants going forward.
Good question.
Enough said.
What I would say is that we have done some analysis at Blue Cross to look at the question which was raised by some of the providers in our alternative payment methodologies. Is there a difference between the ability to manage the care in communities of different socioeconomic? So it's not all of the social determinants of health, but different socioeconomic. And we found that actually, somewhat to our surprise, the answer was no. So in other words, those of our providers who are serving communities of different socioeconomic status, that did not seem to be the determinant of their ability to manage the cost or quality. Now, I will say that for the Blue Cross population, we're talking about commercial members. So for the most part, this is an employed population. So I don't mean to imply that this finding would carry into the provision to other populations, but I would offer that.
What I would say, again, more as an employer, so we are talking about employed individuals. For us, that's shown up not so much in our alternative payment models, but in a discussion that we will be having about the degree to which employees of the state, Commonwealth, people who are covered by the Group Insurance Commission, would be interested in sort of cross-subsidizing for folks who are at the low wage end of the spectrum. And nothing about this has happened yet. It's just something that we know that we're going to want to talk about at the commission as to whether there are vehicles that can be created for that.
Don, you wanted to jump in?
Yeah, just to follow up. First step, your answers are so lucid and complete. I really appreciate it. But can I just, one detail on the site-neutral payment. Can you just say a little more, what, if you went to that tomorrow, what's the downside again? What would be the problem for your members and you?
So what I would say is that from the member's point of view, there is no problem. From the member's point of view, they would say to Blue Cross, why would you pay a different rate for a service just simply based on the location of that service? And it's very difficult for them to understand that. So from a member's point of view, I don't think there's any problem at all. From the provider's point of view, the providers that we work with, what I would say is there are two significant considerations. One is that the providers know that if they provide a service in a hospital-based setting, there's a different level of backup that's available for that service than in a freestanding center. And for some of the providers, they feel that warrants a different level of payment for that service. I would also say that where the provider system is accepting an alternative payment methodology, they feel that their responsibility to Blue Cross and to the member is to manage the total cost of care appropriately, but that each individual service might be higher or lower based on that site of service. And so from the provider perspective, they would say, why is Blue Cross requiring me to, in addition to accepting responsibility for the total cost, price certain services in a different way. Where those two, the provider and the member, do not align is that for many of our members, the only service that they might receive from that provider in a given year is a visit, a scan, and a lab test. And if they have a cost share, let's take a member who has a cost share of up to the first $1,000, they may be paying the full cost of that service, the visit, the scan, the lab test. So for that member, they would say it is their total cost of care, and they do not understand how the costs can vary so significantly between sites. But I would say that's the dynamic that we are, we're.
Can I follow up on Marty's statement? Dr. Strangewater, yesterday, Ron articulated a feeling that, I didn't say strange. I said strange.
It's okay.
I'm sorry.
I've heard.
Give him the mic back.
It's okay.
So, let's see. So the issue that came up yesterday is that can we really expect providers to go against their financial interests to do things? And given the fact that we now know that there is strong positive value with respect to health of reinvesting some money from the acute care side to the other areas. And the question I'm asking is since you're such a strong believer and do so well with the ACO model, do you see and are you reinvesting some of the money that you might save if you're on some form of complete contract to sort of focus on some of these non-clinical important areas that improve health?
Yes and no. So I'd like to answer the question in a somewhat nuanced way. The first is that we have for many years been investing in non-licensed personnel that go to patients' home, have, I'll say, built out the medical home. An important recent investment has been on the pediatric side, where we have these non-licensed personnel that care and do coordination. We've built out a navigator center, and we continue to make investments in areas like analytics, not in food deserts, not in supplements for people's rent, although we may have that opportunity as we work in Mass Health, and we're looking forward to exploring that. On the other hand, I'll say that quite ironically, for a variety of reasons, we're seeing fewer risk patients than we've historically seen, and it's putting a great deal of financial stress on our bottom line. We are fully geared up to go completely at risk, but we don't always see that. And for those patients who come to us under fee-for-service, they get the benefit of that level of care, just as that we would for everybody, the same standard of care of prevention and outreach and the like, which does cost us money. So we are making investments, and we'll continue to do that. It's the right thing to do. Behavioral health is a perfect example. We have a large behavioral health program, and we've recently tuned up our triage process for more intensive intervention and therapy. We need the market to continue to move to these alternative payment models, and the more we get there and the faster we get there, I think the better off we will all be.
Yeah, I just wanted to enlarge. I just learned about a month ago that I haven't practiced in 6 years, so I'm not coding, but that there are actually ICD-10 codes for social issues such as housing security and food security. So it's because we still use the fee-for-service chassis and use coding as a way of doing risk stratification. If providers started using those codes all of the time, first of all, would the insurers then factor those in as risk into their risk stratification, so that then when you did get to global payments based on that are stratified by risk, they would be included. Is that a feasible model?
It's a great recommendation, Dr. Allen. I wish I could answer you and tell you that we're doing it or not doing it today, but I do think that housing and food, nutrition, have an enormous impact on your care and outcomes.
It would also give us data to understand, because I think that to the point that people are employed, and my understanding is that even within communities, suburban communities, when people who are employed, they are suffering some of these social issues as well as some of the poor
So I might
population.
just tag on to the comment, Dr. Allen, to mention and reinforce something that Dr. Joint Maddox said yesterday, which I wonder whether our data sets are robust enough in the state to do geomapping for at-risk populations and have targeted outreach and interventions. They might not have it at a very high level, but we have much more granular data.
So I just wanted to follow up on a topic that's been raised a little bit, and Dr. Allen just mentioned it, just so the difference in alternative payment models between ones that have a fee-for-service chassis and maybe a more complete global payment method. And I wonder maybe both the providers and the payers, if you could comment a little bit on your experience with a more complete global payment methodology and whether there are some advantages to that and maybe what some of the challenges are in sort of implementing that type of system.
Well, maybe I'll start, and that is the availability of, you're much more enabled to innovate. Let me give a little pause here, assuming there are codes and support, regulatory support in order to do that in a full global cap model. Because you're incentivized to make investments. For instance, we've just launched a hospitalization at home program called Medically Home, which will allow us to keep people out of the hospital. That will eventually, as it ramps up, save, we believe, a considerable amount of money. If you're in a full fee-for-service environment, there's no reason to do that. In fact, there might be pushback at several levels to innovate along those lines. The bundled payment is an alignment strategy that Trish has mentioned for total joint replacement. There would be no incentive in a pure fee-for-service world to do that. So I think that as we mature and move more into risk or bundles along that continuum, the further along the continuum you get, the more likely you will see innovation and further cost reductions.
Just to expand on that a little bit, we're not only prepared to take episodic care risk as a specialty provider, but also sub-cap arrangements. As more population health really unfolds, we think that that's the future. But I will say this, that any alternative payment model needs to incorporate the investment requirements in order to innovate. So as an example, care gets improved because we have the ability to predict how things might work when we apply certain modalities or therapies. If we're not investing in predictive analytics, which we are indeed, with appropriate capacity, then we're always going to rely on historical data that's retrospective, that's coming from claims data and not necessarily good clinical data. That requires money. And if we continue to pay on either low price, low cost kind of approaches without understanding the need to invest in infrastructure around improving care, we're always going to find ourselves, sort of looking for that next dollar. And I think transforming care delivery is so important, and it requires an investment, and I think society needs to be clear about making those investments, and it's really very challenging for everyone to be able to do that. So I would say that the alternative payment methodology, certainly we embrace, and we would like to continue to see them evolve and evolve in a way that's very meaningful for all providers and certainly for patients and the payers.
If I could, the bet, I think, of Mass Health and what Trish has just outlined is we're changing the way care is provided, not the way it's paid. And that's the magic.
So, Steve, if I could just follow up on that in a different topic. Both Stanford and Kaiser have been able to substitute telemedicine visits, e-visits, particularly in primary care. And I think Stanford was able to take about 35% out of their primary care visits, Kaiser's 50%, which really frees up capacity and certainly has a cost-saving potential. I wonder if you would talk about kind of how Atrius is approaching e-visits, particularly for primary care, because I think that's a place where there's a lot of ripe opportunity. And then if both Deb and Roberta would talk about the willingness and ability to pay for this, since this is an innovation, not within the payment model, within the provider model, that could be paid for in an innovative way.
So the good news, I believe, is that it has now been proven that telehealth has a positive impact and can have a positive impact in a variety of areas. I would say the earliest consistent reimbursement methodology has been for behavioral health, and so we've turned that on. And there's a great deal of variability in the plan designs that purchasers buy insofar as whether they have fluid access to telehealth. So we have been struggling with how do we turn on, we have the infrastructure, we have the staff to turn on primary care, behavioral health. Indeed, we've experimented with it with a group of patients, but it's very variable. So a patient may not know whether they're covered or not until after they get their bill. And so having that front-end adjudication would help us a great deal in being able to scale and deploy it more broadly. That's our problem. We also have turned on e-consults, so e-consults inside doc to doc, and in-office video visits where it's easier to sort that sort of thing out. But it's mainly been the coding and front-end awareness for what the patient's out-of-pocket costs or full costs would be.
Yeah, I would comment that we're very excited about the potential for telemedicine. We do cover telemedicine for certain primary care visits and for behavioral health. The primary care visits, think of them as the type of visit where the physician does not have to actually touch the patient, but the simpler primary care visits. So we are covering that today for about 1.2 million members. I'm particularly optimistic about the use of telemedicine for behavioral health. We have some access concerns in child and adolescent behavioral health, and what providers say to us is this enables them to practice in a different way, because previously they could only see kids between 3 and 7 o'clock, and there were challenges for the parents in terms of transportation and logistics. Now, technically, that visit could happen during the day, either in school or through another arrangement. So I really see tremendous potential for the use of telemedicine, and I think when we're testifying here 3 to 5 years from now, we'll have seen a significant shift. We're already beginning to see that uptake. There is a learning curve. We only cover telemedicine as a video visit, not strictly audio. So there is a investment by the provider to learn to do a video visit. It's a different way to interact with their patient, and there is a learning curve for the member, and we're going to actively continue to pursue making that easier and pursue supporting that uptake.
I would just encourage continued exploration in this space, because there's synchronous video visits and there is asynchronous video visits, and they both provide value. The asynchronous, meaning not face-to-face, may not be covered. It still work. As our e-consults still work, I think that's a whole arena where if we could essentially take a scan to the future and then work backwards around what would we need to put in place in order to drive down total medical expense and have all the infrastructure, that would be terrific.
David?
each of the panelists here have talked from a kind of organizational standpoint, a commitment to move towards the principles of payment reform. My question really is around how do we engage the physicians on the front line in some of these incentives? And my question is for Dr. Strongwater, but interested in other panelists' perspectives. One of the questions we asked in pre-file testimony was, how is compensation determined for employed primary care physicians of different organizations? And I was, I think, a little surprised to read in Atrius's testimony that 50 to 70% of that compensation is based on productivity, and that only 5 to 10% was based on performance. And it appears to me that that's somewhat odds from what we're trying to achieve in terms of prioritizing value instead of volume. And so interested in how your organization engages physicians in some of these incentives, and what's to stop us from moving further into providing more compensation based on performance?
We have historically paid people in a variety of manners. As I mentioned earlier, we have shifted a little bit more into the fee-for-service space, and we don't have that necessarily that same mindset. This is the short answer is that we have a compensation program that has been in evolution over time. If you work for us, the core expectation, forgetting about incentives, because the core expectation is that you will be a value-based provider. We will provide you with the tools, the feedback, the support, the infrastructure necessary to manage populations of health. While you're at work, we expect you to be productive. And so the good news is that the physicians in their own compensation committee have devised this model. It's not management saying, go do this. This is essentially the group of docs coming together and saying, here's what we really need to do. And so there is panel management, which is a part of our program. There are incentives for quality. For the most part, we just ask people to do work towards the quadruple aim, and we've been very fortunate that people have been doing that. And so RVUs are part of that, because it's a tool that allows us to measure comparatively how hard people are working and to make sure that their time is well spent at work.
Yesterday, David Seltz provided some very interesting information from our staff looking at how well Massachusetts is doing relative to other parts of the country in the 4 major delivery areas. And while we use our hospitals more, we are coming down the differential and so on. The one area that stood out, which is where we're significantly above the national and growing, is post-acute care. So first, Trish, Baptist has long been a pioneer in making statements, which I've heard you make, that when we complete our clinical care, you can go home as much as possible. So I know Baptist has been way ahead on, trying to put people in the most appropriate. So first of all, I'd like to get from you what you've learned, but I also would like to get from the others your sense of what we can do. Obviously, there are patients that should go into a post-acute, and I don't think we want, and we have very good post-acute delivery systems. But the question is, can we get us into a place where people use the most appropriate care? So first, Trish, what's been your experience?
Well, for the last 5 years or so, we've worked very hard with our post-acute care providers to be sure that patients who do need to go to post-acute care are being cared for under Baptist protocols so that they receive the appropriate interventions and rehabilitation in order to be then managed at home as quickly as possible. Having said that, about 80%, now close to 82% of our patients are actually going directly home after approximately a 2-day stay. And this is including complex spine surgery, not just hip and knee replacements. We do certainly many other things. But patients can be cared for at home with the appropriate resources put into place. And I think it's also important to note that the investments in the patient education in advance of the procedure, the expectations and goal orientation rather than stages or silos of care, but goal orientation to the care has been very important. And I would say lastly that our physicians, we are the last bastion of private practice medicine in Boston. We do have some employed physicians. All of our physicians are actually incented in 4 quadrants: citizenship, quality, efficiency, and certainly the importance of productivity while they're at work. But what's really important to us is to be sure that the patient is cared for by the right provider at the right time. And our physicians who do co-manage our service lines are actually incented to be sure that the patient is safely cared for in the right environment. And we measure that. So we'd like to be in a place where 90% of our patients go directly home. We do certainly serve many frail elderly who have significant comorbid conditions who need to be cared for outside the home. But we're always looking at opportunities to improve it.
Yes, sir.
We're fans of sending you home, which is why we've launched Medically Home. We are fans of avoidable hospitalizations right from the ED. We believe there's also an opportunity to manage the post-acute stay, length of stay. So our hospitalists have, our SNFists, which behave a lot like hospitalists, have reduced the length of stay to somewhere between 11 and 14 days, where typically it's around 28 to 30 days. So there probably is an opportunity to avoid the use of post-acutes and then to manage down the length of stay inside the post-acutes.
What about on the payer side?
Oh, what I was going to say is that my strongest experience here comes from my short career as a consultant, because one of the things that was getting looked at really by provider organizations even a couple of years ago was all around, we're back to the conversation about bundles. And it seemed that no matter what kind of treatment episode you were talking about, if it involved a hospital stay or potentially a hospital stay, we were always surprised, and so were our providers, that it was the post-acute care that was the one that had the most variation in cost and was most ripe for intervention. But it wouldn't have occurred to them to look at that or try to manipulate it until they saw the end-to-end cost.
I would say that for Blue Cross, the members that we hear about in terms of post-acute care concerns are mostly within our Medicare population. So recognizing that many of our commercial members would be cared for by the Baptist or Atrius and would still need coordination, it's really more of a factor for our Medicare members. And what we recognize is that the breakdowns are more likely to occur at the boundaries of care, so within the transitions of care. So we have 2 different programs that I would say are designed to collaborate with provider systems in order to manage those transitions in care. The one that is getting the most traction right now is a transitions in care program that we're supporting in the Worcester area, where we have a significant number of Medicare Advantage members, and it's showing some promise.
If I could add one policy change that would help is to, where I get too bold here, require that hospitals have a mechanism to allow transitional nurse liaisons to work in their EDs and other settings. That would allow us to deploy nurses into EDs to avoid a hospitalization directly and or to triage to a lower cost of care. We have triage issues. If you go and you call 911, you're going to an emergency room. And if there was a mechanism to redirect to some other site of service, we could more likely than not reduce emergency room usage and hospitalization rates.
Don?
Dr. Strong, so listening to this conversation, I'm reflecting on your earlier comment about full cap, how you're avid for that. I can see how everything you're talking about would get easier if you had a pot of money to manage the population with, right? And that you said you're going the other direction. So maybe it's obvious to everyone else, but I'm having trouble on what's the bottom. Why are we not going to full cap more quickly? What's in the way?
What we have heard, and I think it's well, what we've heard is that the national payers are not really equipped to sell policies that are full risk in Massachusetts. So if you have an out-of-state, much as Deb was talking about how many of her members are out-of-state, likewise, employers from other states that work here are typically in a fee-for-service arrangement. So that's part of the explanation. Other than that, I think there are other payers in the market that have offerings other than Blue Cross and more traditional Harvard Pilgrim Tufts that are coming in with more fee-for-service offerings, and I suspect that employers see that as an opportunity. Maybe they're lower priced, I don't really know, but that's what we're seeing. We're seeing more fee-for-service.
Employers would rather have the fee-for-service arrangement?
If it's a lower cost, I'm speculating that it would be easier for them. It's an out-of-pocket cost. See, over time, there's no question that if you're in a full risk arrangement, your total medical expense will go down. The management, so I want to compliment Blue Cross for all the efforts in the AQC with working, for instance, in diabetes. Our experience at Geisinger was just after 3 years, your risk of retinopathy, stroke, and renal failure go down dramatically. And if you just avoid one episode of renal failure, you save a lot of money. No fistula, no dialysis, it saves a lot of money. So I think long-term, that's the right approach.
Yeah, I would just add to Dr. Strongwater's comments that the three considerations in going to a full cap are, first, as Dr. Strongwater said, the employers would need to be convinced that the full capitation payment is a value payment and that there are protections in place so that there's no incentive to skimp on care. I feel that that could be addressed. The second consideration is that right now, we, Blue Cross and other health plans, are using claims as the major basis for measuring quality. So while there are some outcome measurements, we do get clinical data on blood pressure and blood sugar, HbA1c. Most of our quality measures are based on receiving claims so that we know whether members have gotten preventive services and whether they've had readmissions, et cetera. And in the past, when full cap or partial cap arrangements have been in place, the providers are not as motivated to submit those claims. As you can imagine, it's an administrative cost and a hassle. So we'd have to overcome that practical issue of how do we make sure that we're getting the data on what services the patients have received. The provider was getting a full cap. And then the third consideration is that the provider would then have to have a mechanism for paying other providers outside of their own system when they provide services. So if there was a full cap and an Atrius patient was seen at New England Baptist, for example, Atrius would need to have a mechanism to pay that, and that's a consideration from the provider perspective administratively. But having said that, we don't have Blue Cross would be open to working with a provider on a full cap if those, what I think of as practical issues are not really philosophical differences, if those practical issues could be addressed.
All right, last question, comment. Karen.
No pressure. So just on that point, that most of the
You get the last.
the data that is out of the system, it comes through claims. It seems to me now that almost all providers are on electronic health records, and there's a lot that needs to be improved in that arena. However, one of the good things about it is there's real-time data about patient status, health status and functional status, and you could get outcome metrics that way. So do you see us using in the future, moving towards a system where we start to use actual real clinical data to manage patient care and manage payments, more either coexisting with some claims data, which, by the way, lags a bit, or instead of it? So anybody can answer that.
We love having an integrated clinical and financial data set. It helps us a lot in building administrative models. I do think that's the future, and I think we're at the beginning of that journey as it relates to some of the clunkiness of the warehouses and data exchanges and interoperability, but I do think that's the future.
Tim, you get the last question.
Thank you.
My last question.
It was relevant 15 minutes ago. So I wanted to just follow up on the conversation around readmission penalties. I asked it yesterday and got shut down, so I'll try it again today. Just wondering, yesterday we heard from a presentation by Dr. Maddox about the unintended consequences of readmission penalties. Dr. Strongwater, you referenced that as one priority for the upcoming debate and discussion, and Debbie talked about how Blue Cross Blue Shield is handling that. I'm just wondering, how do you take into consideration the unintended consequences that were raised yesterday, particularly around safety net hospitals getting hit with this penalty more often than other hospitals? And isn't this really just a penalty for our lack of investment in social determinants of health for these communities? And how do you take into consideration those unintended consequences when setting those penalties?
I just want to make sure I fully understand the comments that were made yesterday, meaning that there could be extenuating circumstances for why a patient is readmitted that are not in control of that hospital. Mm-hmm. And I feel that any policy in terms of reimbursement has to be open to appeal by the provider for extenuating circumstances. I think that any payment policy that we are designing, Blue Cross or other plans, we need to understand those in developing it, and we need to have a dialogue in terms of an appeal. And that's why, while there's some logic for just simply denying payment for readmissions, I feel like we've got to address it in a more focused way, because there can be those unintended consequences.
You know, I would agree with Dr. Maddox's comments yesterday. At the same time, I think there are a number of disease-sensitive conditions that repeatedly lead to readmissions: heart failure, chronic obstructive lung disease, and those are system breakdowns. So I would favor a process where there might be community standards established, even common protocols that people would need to use. And if they follow those protocols and they had a readmission because there was a critically ill patient, that would be great. But if they didn't, then perhaps there should be a readmission penalty. Because certainly a number of these disease-sensitive conditions using heart failure are amenable to home care and home therapy and case management. So at least there's a part of me that says there should be a readmission penalty. And I like Deb's approach of, within an appeals process, and not to create a bureaucracy, but trying to elevate and target just a few disease-sensitive conditions could have a significant impact on readmissions.
So I want to thank this panel extremely well, because, so let me just make a very quick comment. Yesterday, we had a discussion about the fact that Massachusetts came in under the benchmark at 2.8 rather than, and one or two of the panelists said, well, we're doing so well. Why are you asking us tough questions? I mean, why don't you just leave us alone? I'm sort of paraphrasing here, but. So on the one hand, as I look out on the four of you, and I'm sorry to say this, but every one of you have been very successful in different ways, but you can't let up. We need to keep at this, and better than we do where you need to make improvement. We've been critical of Blue Cross when it didn't move fast enough with PPO. You're moving fast enough, but as Don pointed out, he doesn't get it, I don't get it, why we don't even move faster. And what GIC is doing is really, you're ahead of the pack, but more needs to be done. And the two of you in the delivery system, Atrius and Baptist, you're really the head of the pack, but more needs to be done. We can't say, well, we've succeeded, victory is here, and we can walk away. So first of all, I want to thank you for everything you've done, but we also want to keep on you and make sure that you keep at it. So thank you very much. Yeah. All right, we're going to take a 10-minute break, and please come back in 10 minutes. Thank you. Thanks.